Welcome to section 4 of Pulmonology. In this section, I will be discussing breathing mechanics. Let's get started. Before we get into the details of breathing mechanics, why don't we take a step back and review the basic physiology of inspiration and expiration. Recall that inspiration is facilitated by three muscles: the diaphragm, the external intercostal muscles, and the accessory muscles. The diaphragm is the primary muscle of inspiration, and the accessory muscles are generally only used during active inspiration. This would occur, for example, during exercise or heavy breathing. Expiration is normally passive because the lungs naturally tend to collapse, but expiration can be increased when the muscles of the abdominal wall and the internal intercostal muscles contract. Let's draw out what I've just described on the next slide. Okay, so these are the lungs, this is the chest wall, and this is the diaphragm. These represent the ribs, and in between them are the external and the internal intercostal muscles. Near the superior aspect of the thoracic cage, there are accessory muscles, and these originate from the neck and insert on the upper ribs. During normal inspiration, the diaphragm contracts downward, and the external intercostal muscles contract and cause the chest wall to expand outward and up. During active inspiration, the accessory muscles contract and pull the rib cage upward. As you can see, all of these actions cause the space in the thoracic cavity to increase. The increased space results in a drop in pressure. At this point, the overall pressure in the thoracic cavity is less than the pressure in the atmosphere, so air naturally moves down its pressure gradient and into the lungs. So in summary, the increased space results in a drop in pressure, causing air to move inward. During expiration, the elastic recoil caused the lungs to collapse, and this, in conjunction with the relaxation of the diaphragm, causes the volume in the thoracic cavity to decrease. As the volume decreases, the pressure increases and becomes greater than the atmospheric pressure. The increase in pressure causes air to follow the pressure gradient, so air naturally moves out of the lungs. So in summary, during expiration, the space decreases, which results in an increase in pressure, which results in air moving out. During active expiration, the abdominal muscles contract and push the diaphragm upward. Additionally, the internal intercostals contract and pull the ribs inward. Ultimately, this decreases the space more than usual, which results in a more forceful expiration. Okay, with this in mind, let's examine the normal tendencies of the lungs and chest wall. For step 1, it's important to understand the natural tendencies of the lungs and the chest wall. Because the lungs have a high density of the protein elastin, the lungs behave similarly to a rubber band. As they're stretched, the inherent elastic property of the lungs makes them want to collapse. The greater they're stretched, the greater the inward elastic pull. This is called elastic recoil, which I alluded to earlier. So the lungs tend to collapse because of elastic recoil. The chest wall, on the other hand, tends to expand outward. This makes sense. The chest wall has a high density of muscles and connective tissue, so at rest, the chest wall naturally bows outward. With this in mind, let's look at a few figures and talk about these ideas in more detail. When pressure is applied to the lungs, they naturally inflate, which we can easily observe with a figure I'll draw here. So the x-axis is pressure, and the y-axis is volume. And this slope I'm drawing here represents the compliance of the lungs during inspiration. Recall from section 3 that compliance is volume over pressure. In other words, compliance measures how easily something expands under pressure. This figure can be somewhat confusing because it doesn't clarify if the pressure applied to the lungs is positive or negative, and it doesn't give insight as to where the pressure is applied. Let me draw this out to help you see exactly how physiologists come up with this type of figure. So in this illustration, we have the lung right here for simplicity, and it's inside a closed container. So this represents the container. There are also two tubes. We'll call this tube that goes directly into the lungs tube 1, and this tube on the outside of the lungs, tube 2. Let's say that the pressure inside the container, inside the lungs, and in the atmosphere are all equal. Now imagine that someone is blowing air into tube 1. What would happen to the lungs? Well, the positive pressure entering the lungs would exert a force on the lungs, causing them to expand. So pretty straightforward, right? Okay, now let's imagine that a vacuum is hooked up to tube 2 and air is sucked out of the container. In other words, pressure in the container becomes negative, or lower than the pressure in the atmosphere. In this case, what would happen to the lungs? Well, the drop in pressure would act as a vacuum and cause the lungs to expand, similar to blowing positive air inside the lungs. So as you can see, applying positive pressure to the inside of the lungs or negative pressure to the outside of the lungs can cause the lungs to expand. Under normal physiologic conditions, the diaphragm contracts and the space in the thoracic cavity increases during inspiration. The increased volume in the thoracic cavity causes the pressure to drop below atmospheric pressure, and the lungs become inflated as a result. In other words, normal respiratory physiology is more similar to the second example, where we hooked a vacuum up to tube 2 and sucked air out of the container. However, respiratory physiologists commonly apply positive pressure to tube 1 to simulate normal inspiration, and this is how the figure on the last slide is commonly derived. Okay, with this in mind, let's return to the compliance figure. So again, on the x-axis we have pressure, and on the y-axis we have volume. And the slope represents the compliance of the lungs during inspiration. As I just described, the x-axis most commonly represents positive pressure entering the airway, but it could also represent negative pressure surrounding the lungs. The result is the same. The pressure applied to the lungs causes inflation. During inspiration, the lungs need to overcome surface tension forces, so it takes a little extra pressure to get the initial increase in volume. This is why the slope at the beginning of the curve is not quite as steep as the slope right here. As pressure continues to be applied to the lungs, the elastic forces that cause the lung to collapse oppose the continued expansion of the lungs, which is why the slope here begins to taper off. I like to compare this to blowing up a small balloon. If the balloon is completely empty, then it's initially most difficult to get the balloon to inflate. However, as the balloon expands, it becomes easier to blow air into the balloon. Okay, one last thing while we're on the topic. Notice how the curve begins near 0 on the y-axis. This is because if pressure is not applied to the lungs, then the elastic property of the lungs will cause them to collapse, meaning the volume in the lungs would be near 0 at atmospheric pressure. In reality, it's very difficult to completely collapse the lungs, so usually you'll see the diagram shown with the curve originating somewhere about right there. Okay, if we graph out the compliance of the lungs during expiration, we get something like this. Notice how the inspiratory and expiratory curves are different. This is because during expiration, the lungs don't need to overcome the surface tension forces that the lungs experience during inspiration. The difference between the pressure-volume relationship during inspiration and expiration is called hysteresis. Okay, now let's look at the compliance of the chest wall. On this slide, I'll draw out the thoracic cavity so we can more easily understand the compliance of the chest wall. So this represents the chest wall, and this represents a tube going into the chest wall. The major difference between the chest wall and the lungs is that the chest wall naturally expands outward. This means if the chest wall is left to itself, it will naturally contain a volume greater than 0. The lungs, on the other hand, will collapse down to a volume of close to 0 if left alone. If we graph this out similar to the last slide, we get something like this. So the x-axis represents pressure, and the y-axis represents volume. The slope on the curve represents the compliance of the chest wall, as I've drawn here in red. Notice on this figure that without applying any pressure, the chest wall has a volume greater than 0. So pressure is at 0, and the volume is right there. This makes sense. The high density of muscles and connective tissue result in a natural expansion of the chest wall system. Also notice we are including positive and negative pressure on this figure. In order to understand this, let's return to the image on the left. Now imagine for a moment that we blow air into the tube. What will happen to the chest wall? Well, the chest wall will expand because the air exerts an outward pressure on the system. This is analogous to applying positive pressure to the chest wall system. If we look at the figure on the right, we can see that adding pressure causes the volume of the chest wall to increase. So positive pressure causes the volume to increase. On the other hand, let's imagine that a vacuum is hooked up to the tube and air is sucked out of the thoracic cavity. What will happen to the chest wall in this case? Obviously, this would decrease the volume in the thoracic cavity because we're sucking air out, so the chest wall will collapse inward like this. This is analogous to applying negative pressure to the chest wall system. If we look at the figure on the right, we can see that sucking air out of the thoracic cavity causes the volume of the chest wall to decrease. So applying negative pressure causes the volume to decrease. Notice, however, that it's very difficult to get the volume of the chest wall system to 0. In other words, you'd have to have an extremely powerful vacuum to cause the chest wall to completely collapse on itself. It naturally wants to bow outward. Okay, I'd like to mention one more important distinction. With the lung example, we said that applying positive or negative pressure would cause the lungs to expand. This was because we were applying negative pressure to the outside of the lungs and positive pressure to the inside of the lungs. Notice, however, with the chest wall example, that we're applying both positive pressure and negative pressure to the inside of the chest wall. This is an extremely important distinction. This is why when we graph out the compliance curve of the chest wall system, we can see that applying negative pressure will cause the chest wall system to decrease in volume, and when we apply positive pressure, this will cause the chest wall system to increase in volume. If we theoretically applied negative pressure to the outside of the chest wall system, like this, then this would cause the chest wall to expand, similar to the lungs. This obviously isn't done experimentally because it wouldn't simulate normal respiratory physiology, but I find that it's helpful to think about this in order to understand how physiologists come up with a figure like the one on the right. Okay, with this background, let's look at figure 3.5 from your text. This is figure 3.5 from your text, which shows the compliance of the chest wall, the lungs, and the combined lung-chest wall system. As we can see, the x-axis is pressure, and the y-axis is volume. This curve here represents the compliance of the lungs, and the blue curve here represents the compliance of the chest wall. The major addition to this figure is the green curve, which we have here, represents the combined lung and chest wall compliance. Notice that this curve intersects with the y-axis right here, which is a point somewhat in the middle of the two separate curves. This is the point where there is no pressure added or taken away to the system, so the pressure is 0. This makes sense. The lungs want to collapse, but they stay open because of the opposing force of the chest wall, and the chest wall wants to expand, but ends up not being able to expand as much due to the opposing force of the lungs. If we were to apply this experimental figure to a real person, this point here would be similar to when a person has just exhaled a normal breath and the pressure inside the system is equal to atmospheric pressure. In other words, no air is moving in or out of the system. Another name for this is functional residual capacity, or FRC. We discuss this more in section 2, but the FRC is just another way of saying that the lungs and the chest wall are at rest and are equilibrated with the atmosphere. Sometimes you may see the x-axis on this figure labeled trans-organ static pressure or transmural pressure. These terms are actually pretty confusing and, in my opinion, pretty unhelpful. I'd like to take a second to explain the different pressures or forces acting on the lungs and explain what these terms mean, and then why they should also be avoided, in my opinion. So for step 1, it's important to understand 3 different pressures related to the lungs: the alveolar pressure, the intrapleural pressure, and the transmural pressure. Let's pull up a blank screen and talk about each of these. This is figure 3.6 from your text, which shows how the pressures in the alveoli and the intrapleural space change during inspiration and expiration. The y-axis represents changes in pressure, and the x-axis represents inspiration and expiration. We'll focus on alveolar pressure first. Alveolar pressure is simply the pressure experienced inside the alveoli. Let's draw this out to see what's happening. So this will represent the alveoli, and around it we'll draw the other components of the thoracic cavity, which will be represented by this box. This would include, for example, the lung parenchyma, the pleura, and the chest wall. At rest, the pressure in the alveoli is the same as the pressure in the atmosphere. So you can see that on this figure, the pressure is 0 at rest. During inspiration, the space in the thoracic cavity increases and the lungs begin to expand, which means the volume in the alveoli increases. So during inspiration, which I'll draw here, the space in the thoracic cavity increases and the lungs begin to expand, which means the volume in the alveoli increases. So as you can see, I've drawn the alveoli and the other components of the thoracic cavity larger here, which occurs during inspiration. As the volume increases, the pressure drops, so air naturally moves down its pressure gradient from the atmosphere and into the alveoli. This is why the pressure initially decreases during inspiration on this figure, which we can see here. So in summary, the increased volume results in a drop in pressure, and that allows air to move in. As inspiration continues, the air entering the alveoli exerts a force within this space, and this causes the pressure to increase, which we can see here. The pressure is beginning to rise again. At maximal inspiration, which is right here, more air enters the alveoli, causing the pressure to increase until the air in the atmosphere and the alveoli are equal again. So as we can see, during maximum inspiration, the pressure is at 0. This makes sense. The pressure gradients have been equalized, which is why additional air cannot enter the lungs at a maximum inspiration. During expiration, the space in the thoracic cavity decreases and the lungs begin to collapse, which means the volume in the alveoli decreases. So this will represent the volume decreasing during expiration. As the volume decreases, the pressure increases, so air naturally moves down its pressure gradient from the alveoli into the atmosphere. This is why the pressure initially increases during expiration in this figure here. So in summary, a decrease in volume results in an increase in pressure, and that causes air to move out. As expiration continues, the air leaving the alveoli results in less molecules acting on the wall of the alveolar space, resulting in a drop in pressure, which we can see here. At maximal expiration, there is less air in the alveoli, causing the pressure to decrease until the air in the atmosphere and the alveoli are equal. This is why we see the pressure decrease in this figure until it reaches 0 right here. Again, the pressure gradients within the alveoli and the atmosphere are equalized, which is why air no longer leaves the lungs. Okay, with this in mind, let's look at the intrapleural pressure. So I'll draw a lung right here, and this will represent the chest wall and the diaphragm, and this will be a bronchus. Recall that the lungs are surrounded by thin membranes called pleura. If we zoom up on this section of the lung, we can more clearly see the pleura. So this is the visceral pleura, and this is the parietal pleura. And then here we have the chest wall. The space between the visceral and parietal pleura is called the intrapleural space. This is sometimes also called the pleural cavity. The pressure in the intrapleural space is called the intrapleural pressure. It's important to know that the intrapleural space is at subatmospheric pressure. In other words, the pressure in the intrapleural space is less than atmospheric pressure. This is also referred to as a negative pressure. So subatmospheric pressure, or sub-ATM, equals negative pressure. When a pressure is less than atmospheric pressure, it behaves like a vacuum. Now, you may be wondering why the intrapleural pressure is negative. And this occurs for two reasons. First, the intrapleural space grows faster than the lungs in utero, which creates a pressure discrepancy between the atmosphere and the intrapleural space. And second, the chest wall has a natural tendency to spring outward due to the muscles and dense connective tissue, which we described earlier. And this creates an outward pull on the parietal pleura like this. The elastic recoil of the lungs has a natural tendency to collapse inward, which creates an inward pull on the visceral pleura like this. As you can see, the outward expansion of the chest wall and the inward collapsing force of the lungs oppose each other. The pull in opposite directions creates a vacuum-like force within the intrapleural space. So let's quickly redraw figure 3.6 from your text. So this represents inspiration, this represents expiration. This will be atmospheric pressure, positive pressure, and negative pressure. This will represent the alveolar pressure, and this will represent the intrapleural pressure. So during inspiration, the chest wall expands outward even more, and the elastic recoil forces of the lungs increase even more. And this results in an even more negative intrapleural pressure. So we can see the intrapleural pressure begin to decrease during inspiration. During expiration, these opposing forces are decreased, so the intrapleural pressure becomes less negative. So we can see it rising here during expiration. It's important to know, however, that the intrapleural pressure generally remains negative at all times. It may become more or less negative, but under most conditions it remains negative. This is why we can see the orange line, which represents the intrapleural pressure, below 0. Okay, with this in mind, let's move on to transmural pressure. Transmural pressure is exactly what it sounds like. Trans means across, and mural means wall. So transmural pressure is simply the pressure across a wall or several walls. In the context of pulmonary physiology, transmural pressure refers to the difference between the alveolar and the intrapleural pressure. In other words, the transmural pressure, so TP, equals the alveolar pressure, so PALV for short, minus the intrapleural pressure, PIP for short. Under physiological conditions, the transmural pressure is always positive, and conceptually, it is an outward force that contributes to the expansion of the lungs. Let's draw this out to make things clear. This is figure 3.6 from your text, and remember that the y-axis of this figure represents changes in absolute pressure. However, if we were to replace this with actual measurements in millimeters of mercury rather than absolute pressure relative to the atmosphere, the numbers wouldn't be negative. I'll explain this in a second. As we just learned, transmural pressure is the difference between the alveolar pressure and the intrapleural pressure, which will represent with a vertical line between the two. So, like this. Again, this is transmural pressure, which equals the difference in the alveolar pressure and the intrapleural pressure. Notice that the alveolar pressure is always higher than the intrapleural pressure, so if we take the difference between the two, we should always get a positive number. So at rest, the alveolar pressure is normally around 760 millimeters of mercury, or 0 millimeters of mercury relative to the atmosphere. The intrapleural pressure is normally around 756 millimeters of mercury, or -4 millimeters of mercury relative to the atmosphere. If we take the difference between these two, so 760 minus 756, we get +4. So 760 minus 756 is +4. So right here, the difference is +4 millimeters of mercury. Now if we look at the same pressure in the middle of inspiration, so we'll say about right here, we can see that the alveolar pressure has dropped to about -2, or 758 millimeters of mercury. At this same point, the intrapleural pressure has decreased to about -6, or 754 millimeters of mercury. And if we take the difference between these two, we get 758 minus 754, which is +4. The point is that the transmural pressure stays approximately constant throughout the breathing cycle. As I mentioned earlier, the transmural pressure is always physiologically positive, whether that be at rest, +4 right here, at inspiration, +4 right here, or if we were to do the same thing during expiration, we'd get about the same number, around +4. So conceptually, the transmural pressure acts as a force across the walls of the lungs and contributes to the expansion of the lungs. However, in my opinion, the transmural pressure is excessively confusing because it is unnecessary in order to conceptually understand inspiration and expiration. Additionally, it takes two relatively easy to understand terms, alveolar and intrapleural pressure, and combines them into one ambiguous mathematically derived term. Again, this is figure 3.5 from your text, and a few slides back I told you that sometimes you may see the x-axis on this figure labeled transorgan static pressure or transmural pressure. However, I think it's much easier to think of the x-axis in terms of the positive and negative experimental pressures like we talked about earlier in this lecture. So in summary, don't get bogged down with transpulmonary pressure. Now that we've covered the basics of breathing mechanics, let's go over a few examples. Okay, how would the compliance curves of the chest wall and lungs be altered in an elderly patient? In order to get this question right, you need to remember that aging causes the chest wall to become less compliant due to calcifications of the ribs, osteoarthritis, and osteoporosis. So this decreases the compliance of the chest wall. Remember, the slope of the line in this figure represents the compliance. So in this case, we'd expect the slope of the chest wall to decrease, something like this. It's also important to remember that the lungs lose their elastic strength with age, so the lungs become more compliant. So increased compliance of the lungs. This means the slope of the lung curve would be increased. So something like this. Okay, let's do another question. What is the alveolar pressure, intrapleural pressure, and transmural pressure at FRC? Okay, for this question, you need to remember that FRC, or functional residual capacity, just refers to when a person has just exhaled a normal breath and the pressure inside the lungs is equal to atmospheric pressure. Recall that FRC is right here on this figure. This means the pressure in the alveoli is 0, or atmospheric, which makes sense. Air is not entering or leaving the lungs, so the pressure gradients must be equal. So alveolar pressure is 0. This is also the same as 760 millimeters of mercury. On the other hand, intrapleural pressure is always negative because the chest wall has a natural tendency to spring outward due to the muscles and dense connective tissue. This creates an outward pull on the parietal pleura, while the elastic recoil of the lungs has a natural tendency to collapse inward, which creates an inward pull on the visceral pleura. Remember, the outward expansion of the chest wall and inward collapsing force of the lungs oppose each other, resulting in a constant negative pressure within the intrapleural space. So even when air is not entering or leaving the lungs, the intrapleural pressure is negative. So intrapleural pressure equals negative. Finally, transmural pressure must be positive because the alveolar pressure is always greater than the intrapleural pressure. So remember, the alveolar pressure is greater than the intrapleural pressure. And as I demonstrated earlier, if the alveolar pressure is atmospheric, or about 760 millimeters of mercury, and the intrapleural pressure is slightly less than that, usually around 756 millimeters of mercury, then the transmural pressure would just be the difference between the two, or about 4 millimeters of mercury. So transmural pressure is about 4 millimeters of mercury. Okay, let's do another question. How would alpha-1 antitrypsin deficiency alter the curve? I explained this disease in detail in section 1 of this chapter, so I'm not going to spend as much time on it now, but simply put, alpha-1 antitrypsin deficiency results in excessive destruction of the protein elastin in the lungs. So decrease elastin. Elastin is what allows the lungs to behave like a spring and recoil during expiration. If a patient has less elastin, then the lungs can more easily expand and tend to not recoil back as easily when they're stretched. Another way of saying this is that the lungs are more compliant, so increased compliance. As we know, the slope of the line in this figure represents compliance, so increased compliance would mean the lung curve would look something like this. Okay, let's do another question. How could bleomycin toxicity alter the curve? Recall that bleomycin is an anti-tumor drug commonly used to treat testicular cancer and Hodgkin lymphoma. It's important to remember that one of the most commonly tested side effects of this drug is pulmonary fibrosis. Fibrosis simply means the connective tissue has become thickened and scarred. So in this case, pulmonary fibrosis would result in thick, non-compliant lungs. So decreased compliance. And as we know, the slope of the line of this figure represents compliance, so decreased compliance would mean the lung curve would look something like this. Okay, let's do another question. How does the pressure in the intrapleural space change during a pneumothorax? Before we answer this question, let's quickly redraw a zoomed up view of the intrapleural space. So this is the chest wall in red, this is the parietal pleura, and this is the visceral pleura. Remember, the space between the visceral and parietal pleura is called the intrapleural space. We'll do IP space for short. Remember, the chest wall has a natural tendency to spring outward due to the muscles and dense connective tissue. This creates an outward pull on the parietal pleura like this. On the other hand, the elastic recoil of the lungs has a natural tendency to collapse inward, which creates an inward pull on the visceral pleura. As you can see, the outward expansion of the chest wall and the inward collapsing force of the lungs oppose each other, which creates a vacuum-like force within the intrapleural space. This vacuum-like force is incredibly important because it holds the lungs to the chest wall and prevents them from collapsing inward. During a pneumothorax, the intrapleural space is exposed to the atmosphere, so air enters the space and the pressure equilibrates with the atmosphere. In other words, the intrapleural pressure is no longer negative, it becomes zero. This means the vacuum-like force of the intrapleural space is lost, so it can no longer hold the lungs to the chest wall, and the lungs spontaneously collapse due to the unopposed collapsing elastic forces of the lungs. So in summary, the pressure in the intrapleural space goes from being negative to zero. Okay, let's do one final question. Why does a pneumothorax result in hyperresonant percussive sounds and diminished breath sounds? Well, as we just learned, a pneumothorax results in a collapsed lung. Normally, percussion of solid structures produces a dull sound. So solid results in a dull sound. However, when the lungs collapse, this results in a hollow air-containing space, resulting in a hyperresonant sound. So hollow structures produce hyperresonant sounds. The breath sounds are diminished for two reasons. First, the lungs are further away from the chest wall, so it's more difficult to hear breath sounds. And second, the patient is unable to adequately ventilate because the lung is collapsed, so it's more difficult to hear air entering and leaving the collapsed lung.